All right, everyone, let's begin. This is our second Paincast. It is the production of the AOPT PainSig. I'm Eric Kruger, and I am the Ed Chair, Vice President of the PainSig. And in this Paincast, we're talking with Doctors Antoinette Spector and Dr. Jake Magel. And we're talking about pain, the opioid crisis, and physical therapy. So our two guests here are experts in this area and both the overlapping areas of pain, physical rehabilitation, and opioid use. And so we're really great to have their expertise. As always, this is more of a interactive webinar format. So if you have questions, I'm going to be sort of monitoring the chat as we're going along, but feel free, if you have questions, put them in the chat. We'll try to get them to our guests, or you can always unmute yourself and then jump in. It's always a little bit easier for me if you raise your hand or put something in the chat. We'll be recording this, so you're able to watch this at a later time point, and we'll put this on the AOPT PainSig website. So let's begin with some brief introductions. So Dr. Antoinette Spector, why don't you begin with you and talk about yourself, how you came into this area, and where you're at.
All right, well, hello everyone. I am an assistant professor at the University of Wisconsin-Milwaukee. So I'm part of the core faculty in our Doctor of Physical Therapy program, which is in the Department of Rehabilitation Sciences and Technology. So my clinical experience is primarily in outpatient orthopedics. I spent most of my time, about almost 10 years in clinical practice, and was a board certified orthopedic clinical specialist. We were just laughing earlier. I actually took continuing education courses with our other guest, Dr. Magel. And I feel like he trained me to be a very solid orthopedics clinician. And then after that, I decided I wanted to go back to school and get my PhD. So I enrolled full-time in a program in public and community health, and really wanted to have an immersive experience in public health research. And my program really emphasized the social determinants of health, community engagement, and health equity. So that's really when I got my first experience with research on the opioid crisis. My primary doctoral advisor had a federally funded study examining the opioid epidemic. And I really, as part of that research project, I became really aware of how important it was to have diverse perspectives at the table, and how my experience as a PT doing pain management was really valued on our research team. And I think that experience has really kept me really engaged with the opioid crisis and wanting to explore more our role in mitigating the harms of substance use. And I think we have a bigger role to play in that. And so I am excited to be here to talk more about that.
Great. One thing I'll be interested in hearing from you both is if you sought out opioids, or did the opioid crisis seek out you? But we'll go to Dr. Jake Magel next and give us a brief introduction.
Yeah, thanks for having me. I'm I guess a newly minted associate professor at the University of Utah in the Department of Physical Therapy and Athletic Training. And my primary motivation for really learning and studying more about opioids and how physical therapists can impact the opioid crisis and help to manage patients who are taking opioids. I was really motivated by my experience in just managing patients myself for years. Prior, I was a director of a spine specialty clinic in a large healthcare system for a while, and I managed many patients who were on the way to surgery, trying to keep them out of surgery, and then manage patients after surgery. And many of those patients were taking opioids appropriately and sometimes inappropriately as well. And so that was my primary motivation. And I'm now working on I'm a KL2 scholar, which is a NIH-funded training program for looking at how patients after spine surgery are using and potentially misusing opioids. And I have a great collaboration working with some addiction medicine specialists here at the University of Utah. And I'm affiliate faculty in what's called the Program for Addiction, PARKA, Program for Addiction Research, Knowledge, and Care, I think. And so that's really been interesting opportunity for me in really kind of immersing myself in more sort of the substance use space and how we as physical therapists can play a role in it. So it's an exciting place to be.
Great. So before we get into like specific questions for you both, I think it would be good to kind of get some key terms out of the way, or just like definitions. So a couple things that we'll be talking about today is opioid use disorder, and that's kind of, as a field, you know, we used to use the terms like addictions or substance abuse or abuse, and we've been more used to these use disorders as a way to decrease stigma around people using opioids or other substances. So when we use that term opioid use disorder, it's kind of that same area as those previous terms. There's a specific criteria related to this diagnosis. We're not going to go into this, but this goes into like cravings for opiates, ability to control opiate use, hazard opiate use, and this has very specific DSM-V criteria. Another term we might use tonight is opioid misuse, which is when someone gets a prescription for an opiate, they, you know, whether that's post-surgical pain or for chronic pain, they start using those opiates in a way that's not in line with that prescription. So that's opioid misuse, which is kind of like a form of opioid use disorder, but very specific related to that prescription. And then there's medication for opioid use disorder, which is specific medications that people take to help them manage and mitigate the harms of opioid use disorder. Some of these medications you might be familiar with, such as methadone or buprenorphine, or otherwise known as Suboxone. And then more recently, a term that I don't know if all physical therapists are aware of this, but with the news about the number of overdose deaths that have been occurring, and that we were just over, I think, 100,000 this last year, where that was 2021. The word fentanyl, what is fentanyl, and it's a synthetic opioid that's much stronger, that is being made illicitly by drug manufacturers, that is getting into all sorts of drugs in the illicit market. But this has created a huge crisis in that fentanyl is so potent and the dosages are so variable that this is part of the reason why we're seeing this one part of the reason why we're seeing this ginormous explosion in overdose related deaths. So those are some of the kind of the terms we might be throwing around. Obviously there's other ones, but I guess we'll kind of go back to Dr. Magel, and I know you've done some specific research related to kind of physical therapists' attitudes and beliefs and around opioids and their knowledge base here. And so I was just wondering if you could start us off by kind of summarizing some of that work that you've done. Yeah.
Sure. So I became very interested in learning, you know, are physical therapists really ready to take on a greater role in managing patients who might be either misusing opioids or have an opioid use disorder. And again, those are two distinct terms. And so we conducted a survey through the Academy of Orthopedic Therapy, and you know, the vast majority of physical therapists felt like physical therapists can play a role in managing misuse. In the study we just described prescription opioid medication misuse, and then defined addiction basically, and then defined misuse. And so they were kind of lumped into one term there. And physical therapists, about 87% of them felt like they could play a role in helping to manage these patients, manage the actual behaviors, not just their orthopedic conditions, but the patient's behaviors. And yet few physical therapists had any formal training. I think if I can recall, there was about 25% had no education at all in how to manage patients who might be misusing opioids, and I think roughly about 60% had like 1 or 2 hours of training. And so we feel like we can play a larger role, but we really don't have as much maybe training as maybe we should in this space. And then when we assess their attitudes related to managing patients with opioid misuse, and again, I'm kind of lumping that into addiction and misuse, just specifically related to this research study. We found that if physical therapists felt like they were adequately prepared, and many of them did feel like they were adequately prepared despite having any kind of formal training, they were more likely to engage in different behaviors, like more likely to screen patients, or more likely to refer patients for treatment, more likely to ask them about their potential opioid misuse, and greater confidence in those things, in those behaviors also. And so when therapists felt adequately prepared, they were more likely to engage in these behaviors. And so this is sort of baseline information that we can really use as a starting point to say, okay, where are we as physical therapists in our beliefs about how, or at least how we think we behave with these patients, and I hope it's a springboard for us to provide greater training opportunities and actually study different types of training for physical therapists to manage these patients.
So that's a great point. And that's kind of springboarding off of what Antoinette said about the role of PTs playing a bigger role as physical therapists. So Antoinette, like, how do you see us as physical therapists playing that larger role in this space?
Yeah, I think it's kind of twofold. I mean, I think a good point is, do we have the training? Do we have the time and the resources to play a larger role? And I think that's a valid conversation that we should be having. And I think, but the other side of it is that we are already engaging with people who are, at risk for currently actively misusing opioids and maybe living with opioid use disorders, whether we know it or not. And one of the things that Dr. Magel used to say, actually, when I took courses from him, is just because we haven't seen a condition doesn't mean that it hasn't seen us. And so we are already engaging with people. And so I think we have to create spaces where people are comfortable and willing to, disclose that information to us, because it might have real relevant effects on their plan of care. And so I think creating safe spaces where we can at least understand people's stories, what their situations are, I think is really the first step in creating environments where people feel comfortable disclosing how opioid misuse or substance use in general might be affecting them and potentially their treatment goals. And then the second part of that is then knowing what to do when those conversations happen. And I think that's the larger conversation that we need to have with respect to understanding how to refer people to treatment, having a cadre of people that we could refer to who could provide services that people might need. But I think at the very least, we can be meeting people where they're at and having those conversations right now so that they know that we are someone who is a supportive person on their team who will advocate for them, as we do for so many other people with whatever conditions they might be dealing with.
Great. Yeah, there's a lot of different ways we can go based on your guys' 2 comments. And I just want to reiterate to those joining late, if you've got a comment or you've got a question, please, this is meant to be interactive. So feel free and jump in there.
Eric, may I just say something additional, just sort of spark my thoughts here, some of the stuff that Antoinette was saying, that, we're one of the few providers that sees patients in relatively rapid succession. I mean, once a week, sometimes twice a week, over several weeks or even months at a time. And so we're really well positioned in care pathways to interact, get to know these patients, and develop a trusting relationship with the patients, and a therapeutic alliance, so that these conversations can actually happen. And we are, if you're seeing patients in pain, like Antoinette mentioned, these patients, many of them are using opioids. In fact, if you are roughly about 25 to 30% of patients who are using opioids for greater than 90 days or on long-term opioids, it's been estimated that 25 to 30% of those patients might actually be misusing them. And those patients with musculoskeletal conditions, with chronic pain and musculoskeletal conditions who are on opioids for 90 days or more might be misusing, as in using them in ways other than prescribed, not necessarily having an opioid use disorder, but using them in ways other than prescribed. And so we are seeing those patients for sure. They're coming through our door, guaranteed. I think we have a tremendous opportunity as a profession to figure out really how we can insert ourselves in these care pathways to help play a much greater role in these patients, in helping these patients. So in preventing the adverse effects of people that are potentially misusing them, go on to opioid use disorder, or may potentially overdose in the future, being able to prevent that.
And that's a great point, Jake. I think, I see Stephen has his hand up. Let me jump in there with one comment, and then we'll go to Stephen. We have these patients with chronic pain, right? And some of them are on chronic opioids for their pain. And those are not, being on chronic opiates is not necessarily having an opioid use disorder. And I think some of the research that you've done, Antoinette, and we'll go to Stephen, then we'll go back to you, and we can kind of talk about this, because I think this is related. This idea of safe spaces, therapeutic alliance, and stigma that individuals feel, whether they're chronic pain patients on chronic opiates or individuals that have an opioid use disorder. So Stephen, I saw you raised your hand, so feel free to jump in here.
Yeah, I just want to make a general comment that, this is not unlike our profession, right? Because we really have sort of been the trash can of rehabilitation, where we pick up a lot of what other people don't, because we spend time with patients. So to Jake's point, I think that's a really important point. But I think it's true for us in general that, if you look across the spectrum of the evolution of practice, whenever there's a new innovation in practice, people are really hesitant to pick it up. Why? Because they're not familiar with it. When you're not familiar, you're going to push away from it. So I think what I'm really pleased about this opportunity to meet here and to sort of have these webinars is that it's going to help us be more familiar. I mean, we had one a few weeks ago with Jake on psychological issues and trying to, where are the screening tools for us? I think once we understand what the best screening tools are, what it is that we need to know versus what it's nice to know, how we can work that into our clinical reasoning, because we already have that framework and we already know how to establish a patient alliance. I can see us being an extremely effective tool, but I'll be the first person to stand in line and say that, we listen, we hear, but I'm not so sure I have all the tools. And I'm hoping that that's what we're going to get out of this, is really what are the best tools? And then what can we take back with that, not just to the patients, but to our students, our residents, our fellows, and try to get them oriented as well, because this is a large scale project and large, many hands make light work. So I'll inhale now, but that was just my comment. And I really appreciate you guys putting this together, because I really do think this will be quite helpful for all of us.
Great, thanks, Stephen. So tools are important. Standardized assessment tools. Let's come back to this idea, and maybe we'll try to round out the conversation later, looking at some instruments. But Antoinette, I know that your work has examined, especially the vulnerable populations. So give us your perspective on this.
So kind of what you're alluding to is this idea of stigma or attitudes towards people who may be on chronic opioid therapy or potentially misusing opioids or have an opioid use disorder. And I believe people are coming around in all different spaces that this is a real threat to all of our ability to kind of get on the other side of this crisis. There's a lot of potentially negative attitudes towards people with substance use disorders, and that includes people who have opioid use disorders. And there's also some stigma around medications to treat opioid use disorders. And so I think one of the big things is us as a profession being mindful of where we fit into that conversation. And so there's a lot of talk nowadays about unconscious biases and some of the things that we hold that we may not necessarily be aware of, but that certainly can affect our interactions with people who have substance use disorders, or who may, be connected to people who have substance use disorders. And so I think part of that conversation and the research that we've done has found that, people, they understand that they are, people in our society who are considered potentially less valuable, who may not have, people may not feel that it is worth it to provide care to them because of their misusing substances. And that can come through not just in, broader society, but even within the healthcare system, including within our clinical spaces. And so I think we just have to really take stock as a profession, the type of language that we're using around substance use, educate ourselves on, what are appropriate ways to talk about this, and how we might be doing things even unintentionally that may create an environment where people may not feel comfortable disclosing their substance use because of fear of rejection or fear of how that might influence their care. And so while we don't know exactly how stigmatizing attitudes may affect opioid use behaviors, specifically, I think we can safely say that negative attitudes toward any group likely has a negative effect, whether or not we know exactly what that might look like in terms of people's willingness to engage with us, interact with us, seek care with us, and potentially its ability to continue to exacerbate both their pain and their opioid use in a negative way. And so these sometimes can be tough conversations to have, but I think we would be lying to ourselves if we didn't at least admit that we probably all hold some attitudes towards substance use, or substance use behaviors that could be discussed more openly, and that we probably need a larger conversation within our profession about what our role in this is, and how we may be creating an environment that is not as safe as a space as we would like for people who are entering into our clinical environments. And so one thing is to ask people, to be able to screen for substance use, but we also have to ask, do people feel comfortable or safe talking about that? Because you need both of those things to happen if we're ever going to, make a dent or move forward in this conversation.
Yeah, one question that pops into my mind related to this is, thinking about how, we teach a lot of our students, like choose PT. I mean, that's sort of a public facing front that the APTA has put on about choosing PT, and mostly in opioid naive patients being patients that have not been exposed to opioids, that go down this conservative route before you go down opioids. But I think, and I don't know this, but I wonder sometimes if the messaging around that gets conflated with all, we need to steer everyone away from opiates, or how we come on potentially very strong with a very specific perspective. And maybe that's what I hear you saying a little bit. These are things that I wonder about as we teach our students this. And I'm interested to hear from both of you, Jake and Antoinette, about this, about how we kind of broaden this space, and when we're both training, but working with our patients.
Well, I'll take a little bit of a stab here. I'll just step back a little bit. I think Antoinette mentioned something about the patients and how do they feel about having these conversations, and I just finished analyzing the results of a survey that we sent out to all patients that attended a PT visit, and at least an initial evaluation for a musculoskeletal condition here at the University of Utah. And we asked them questions about, how would they feel if the therapist, do they agree that a therapist, if they suspected opioid misuse in the patient, that the physical therapist should be asking them about it, or use tools to screen for opioid misuse, or refer if the therapist suspected opioid misuse. So we asked them, and would they actually truthfully disclose that they were misusing opioids? And so, we got a little bit of the information from the physical therapist side and how they feel about it. And so we were really curious about, well, how does the patient feel about physical therapists actually engaging them in these conversations? And overwhelmingly favorably, they thought that the physical therapists had a role, and so. I think that's pretty interesting, and should give physical therapists a little bit of permission, to have these conversations. It's only one healthcare system and just the state of Utah, and so all the problems with surveys, it's not really generalizable, and so on. But at least it's sort of some baseline information to say, okay. Patients are willing to have. They might be willing to have these tough conversations with PTs. And I'm getting slightly off track here, but we're also very interested in how do physical therapists actually, how do they go about the mechanics of having these conversations? And so we just submitted a grant to explore what physical therapists are willing to do in this space. Are they willing to, what conversations are they willing to have? Are they willing to use tools? Because Antoinette mentioned, using tools and getting PTs to do these things. But are they even going to do it in busy, swampy lowland of messy clinical practice with the day-to-day stuff to pull out a tool, to do this with a patient? Hopefully we'll be learning a little bit more about that in the near future, if it gets funded. Now I can't even actually remember what the original question was, Eric. It was just, Antoinette's great comments just sparked some thoughts, and I just kind of went with it. So I don't remember what you asked me.
Well, I don't mind piggybacking off of what you said, because that's really intriguing. To learn that PTs or that patients are wanting and willing to have these conversations with us. And I think that's important to get their perspective. And I think it should give us greater confidence. And it's not terribly surprising. I mean, I think we can all speak to relationships that we build with patients, even in an initial evaluation, because of the time that we can spend with them. And the environments in which we work. So I think it is really encouraging to hear that. And then the other thing that I think about is, setting up environments where these conversations can happen, and making sure, if you work in a busy clinic with curtains and things of that nature, and, where can these conversations happen, making sure patients feel like they have their privacy to talk about some of these things and what might be connected to their substance use. And the other part of it too is time. These are not quick conversations necessarily to have. And so I think, we have a lot to think about. We're talking about the mechanics of this, and I think it is something we can do very well. But just like so many things, even talking about screening for mental health distress, a lot of these things are things that can't be rushed, and there might be, issues surrounding it that we have to be really mindful of. So I think these are really good conversations to have. But I think the point is we should be having the conversation, because I think on both sides of the coin, we all see that there is a need for this within the profession, both from the side of the patient and from the side of the clinician.
Thank you for mentioning that. And the third side is actually from the physician standpoint. And so if, how a physician would react to a physical therapist calling them up and saying, your patient is misusing opioids. Is that, how do we have that conversation? And is that going to be met with some resistance, like, don't tell me how to treat my patient, or maybe the physician might completely cut the patient off from opioids, and that might be inappropriate. And so that's actually the subject of another grant that's in preparation, is how do we interact with the physician side? And so, I think there's a lot for us to learn here, for us to get to get, to dive deep in this, and not just with opioids, but also, we're really well positioned to screen patients for other substance uses, like, patients who are potentially misusing alcohol. And we've got a survey out right now to our patients that are accessing physical therapy on that very question. And so, no results to share, but maybe one day.
I know probably a number of our guests are interested in specific tools that they could use for screening. And I want to ask our guests, one kind of like general question is like, are we at a place where is there a tool that we should use here, and maybe what that is? Or is it more about creating that space for that tool to be used? Like, how do we use that tool in this setting? Just get your thoughts on that, and then we'll go to Stephen. I see his hand is raised, so we'll go to Stephen after that. But I think that this is like really pertinent to like the points that you just made.
I guess I will take that. I mean, my understanding is there are tools that are out there that may not necessarily be dedicated to use by physical therapists, but have been developed primarily for prescribers to try to understand if it is appropriate to prescribe medication and what risk factors might be out there for people that would put them at risk for misusing opioids. I think these are valid tools. But I think there's probably work to be done and maybe conversations to be had about if those tools are appropriate within the physical therapy environment. So there's the opioid risk tool is one that comes to mind, and it really goes through various risk factors. But I think it's really meant to be for prescribers, not necessarily for PTs, but that doesn't necessarily mean it wouldn't be appropriate for our environment. And I think the conversation about where does it go in the workflow? Like, is this a conversation or a tool that's used at the intake? Is this something that, you follow up on multiple times? Is there just a one item or two that can be pulled from some of these things that you use routinely so that it's efficient? Is it something, is it something that you give to someone, while they're in the waiting room that they can do anonymously? Is it happening within your subjective exam? I mean, I think there are, in my opinion, there are more questions than answers when it comes to this, but I do think there are tools out there that could be looked at. But I am hesitant to say that we should automatically apply those tools to our particular setting. And I also believe that we should never screen for something if we are not prepared to address it. And so screening for something and not being prepared to know what to do with that information, I think is inappropriate. And so I think there has to be a lot of thought into what's the right tool, how do you apply the tool, and what do you do with that information if someone were to screen and say that they are at risk? Do you have the infrastructure set up to actually assist that person, other than just having that information known almost gratuitously with no sense of what you would do with it once you got it? So I think we have to be really intentional about what tools we're using, and even no matter what tool you use, what will you do with that information once you have it?
So can I'll just piggyback on that a little bit. There's such good points. The best tool is the tool that the patient will fill out and the physical therapist can integrate. And those of us that routinely use outcome measures on our patients with orthopedic conditions or other conditions know how incredibly challenging that is, just for somebody with low back pain. I'm currently using in a study the current opioid misuse measure, or the COM. There's a short version, is a 9-item questionnaire. I think it's 9 items, and it's pretty easy to score. And that's in a research setting for patients that have consented and not using it in routine practice. And then I'm also using the PROMIS medication misuse measure, which measures the patient's potential opioid misuse as compared to the general population. It's a little bit hard to understand, and but those are but it's tends to be easy to fill out for the patient, and it has a it's average number of items because it's computer adaptive technology. Average number of items is, I think, 4 or 5 that the patient completes, so it's relatively quick. And so, I hope to be able to, engage in more conversations about the types of measures to use. I certainly can't say that either one of those are the best, because I'm not using either one of them in routine practice. We currently use the PROMIS measures in routine practice in physical therapy, and so you could create something within PROMIS that would ask the patient, "Are you currently taking opioids?" That would then trigger them to complete that measure. But then it's just another thing for the patient to complete on top of the pain interference and physical function, and patients are already complaining about completing those things, and so it is a challenge, really.
Yeah, and I'll just drop in a little bit. I mean, there is screening questionnaires for substance uses on some intake questionnaires, whether that's alcohol use or tobacco use, and so conceivably you could adapt things that are developed by NIDA, National Institute of Drug and Drug Abuse, which has various anything from a brief to a larger questionnaire. The assist and the TAPS come to mind, but those may or may not make sense, and they are burdensome, and they could also, potentially without additional context, be off-putting, getting that thrown at you, not as a patient. We don't know that yet. So I think this is a really interesting conversation about where we're at with this. I think let's go to Stephen, and then I want to come back to some of these ideas. But Stephen, go ahead.
No, thank you for having this and letting me speak. One of the things that I find really, there was a Davenport article in 2020 where he kind of laid out a population health framework to addressing the opioid epidemic. And I think we tend to be a little bit more focused, even as a profession, so much on the front side of it, getting those people who are opioid naive from ever starting to use opioids, or those who just start using it to kind of to get them off it, to reduce their dosage and so on. I think some of the work that I've seen you guys do in terms of physical therapist management of opioid use disorder and some of the practices regarding that are awesome. I think another thing we need to really focus and shift on is we really still need to focus much more in the secondary, tertiary prevention, where we're looking at people with full-blown opioid use disorders and that kind of thing. And there's a wealth of information if we start looking into the harm reduction type research and literature. And even as something as simple as naloxone training, which is has become a research interest of mine over the last couple of years, we really do not know how to do something that's very simple and life-saving and really should be a standard across the board, similar to CPR. And I know it doesn't mirror a lot of our practice, and there's not a lot of people work in treatment centers. But I think that there's a great opportunity there if we get into those spaces, because that's also a place where we can contact other providers. If you do naloxone trainings in your community, or if you do naloxone trainings for other medical groups and other healthcare providers, this is ways we can start then shifting it so we're involved in those conversations where we can stop it ahead of time, because people want to have those conversations about where people are ending up, not where it could have been prevented necessarily.
Great point, Stephen. Antoinette or Jake, do you want to jump in here on?
Well, yeah, the APTA has a position statement on naloxone training, and says that basically says that all physical therapists, that all physical therapy environments should have naloxone on hand.
We've done, the research is probably going to come out soon, that statement does not reflect clinical practice at all, and it is. There's going to be some findings there.
I have no doubt. I guess I'm just pointing out that at least the profession, the leaders say that this is important, and you and I and presumably everybody on this call believes that is certainly important. But what is in practice is I'm sure it's we're going to learn something interesting from your work, Stephen.
Yeah, and I think to piggyback on that, I wholeheartedly agree. I do some work in harm reduction and am a big proponent of us becoming more aware of what harm reduction even means, and how that is something that should also be discussed when talking about our patients, particularly those who are using opioids. And I think the other thing is, not in addition to us being clinicians, we are also just citizens. And so I think in addition to us having that training within the clinical environment, CPR, I've used CPR in my own home. And so I think we as healthcare professionals can be leaders in having training like CPR, having training with naloxone, so that when we are out in our communities, we are able to provide those services, in addition to the fact that we also have a lot of other medical training. The other thing I think is that it is a good way to start to break down stigma around substance use and around opioid use when you have trainings, when you have conversations about naloxone and administering it and how you go about those things. And if you post signs or let people know that you have Narcan on site and things of that nature, it creates an environment where people are like, oh, okay, like people are here doing harm reduction. So I think there's lots of things that it does outside of not just saving lives, but also creating environments where people are like, oh, they're on board with this. This is something that PTs do. And so I think it also can help to break down stigma or let people know that these are things that we are supportive of.
So I want to jump in here. So naloxone training has been brought up and harm reduction. And I think we're kind of moving, we've talked a bit about like assessment and like, these early conversations and some tools and whatnot. But now I think we're like taught more in this space of like, what do we do? I'm wondering if you both could like give us just a brief definitions. What is harm reduction, especially in relationship to opioid use disorder and naloxone training? Because some people may not be aware of exactly what you all are talking about.
So when I think of harm reduction, I think of, policies and practices that try to reduce harms related to substance use broadly. And so that might be things related to naloxone, even if we think of things related to injection drug use. So having access to clean syringes, access to things that can help you clean your equipment. It is trying to provide opportunities for people to mitigate the harms related to substance use, as opposed to the pure focus being on just stopping substance use. And so one of the mottos with harm reduction is you're meeting people where they're at. They may not be ready to stop using substances today, but they'll never be ready if they're not around to do it. So the more that we can mitigate the harm through keeping people alive, using things like naloxone, helping them to safely use substances so that they're not, getting infectious diseases and things of that nature. It is trying to reduce harm related to substance use, which is not only just getting people into treatment to completely stop using substances, if that makes sense.
Yeah, that's great. And then, to contrast that, like the previous, and the opposite of harm reduction is that abstinence only model, which you talked about, which is like, we just need to stop everyone from using substances altogether, and how that could actually be harmful in itself, because that's a very difficult task, and it doesn't actually reduce the harm of the substance use itself, which is the actual aim of what harm reduction is going for. So naloxone training, what is that? What's that all about?
So these are trainings that are offered in almost every community, often administered by public health departments. You can get training sometimes through harm reduction programs dedicated to harm reduction. But essentially, it is training. Oftentimes, they're offered free within the community, but they can also be brought on site. And it is training in both how to recognize the signs of an overdose, how to administer medication, the naloxone or Narcan, and then typically at the end of it, it actually gives you the supplies for you to do so. So I would say it's quite similar to, a first aid CPR training. First, you have to be able to assess what is happening. And so there's training on just understanding what an overdose might look like and how it may not look exactly how you tend to think it looks like, and some of the different signs and symptoms to recognize. And then it actually walks you through the different types of naloxone that you might be able to administer. Sometimes it's a nasal spray, there's an injectable version. And then typically at the end of it, you're given Narcan to keep on your person or within your environment so that you can use that if you were ever to be in proximity to someone who might be going into an overdose, and you can administer that fast-acting overdose reversal medication. And I should also mention, similar to like other trainings, it also talks about what you should do after the fact. And so how long people, what it might look like after the medication is administered. So walking you through that step by step.
I think if I'm not mistaken, that there's over 40 states that pharmacists can distribute naloxone just to the public without a prescription.
I have a paper under review right now. Hopefully it'll get published here soon. But yeah, it's looking at a lot of laws have changed to facilitate this. And so typically in almost every state, pharmacists have a standing order. So there's a standing order administered by the medical director that allows pharmacists to administer Narcan over the counter without a written prescription, because that prescription is already been prescribed by the state medical director. Now, it should be noted that when you get naloxone in the pharmacy environment, unlike some of these community-based trainings, typically it's going to come at a cost, like all medications do, but there are quite a few insurances that are covering naloxone medication. And you'll also see pain management physicians, co-prescribing naloxone with opioid prescriptions so that they could get it at the same time that they might be picking up an opioid prescription at their pharmacy.
Antoinette, during your in the paper that's in preparation, did you look at like the risk to people in administering naloxone to patients, like legal risk or anything of that nature?
This paper doesn't talk about that in particular, but the study that we're working on more broadly is looking at things such as state laws related to that. And many states have Good Samaritan laws. There are also laws that provide some immunity to prescribers and administrators of naloxone so that they are not held liable in any way for administering naloxone and what the consequences of that might be. So a lot of states have put in place laws. A lot of times there's some sort of immunity provision within the law that provides, protection for individuals who are administering Narcan, and also for professionals who are prescribing it.
Great. That's a great background on that. And I can say this is the first year with our PT students. In a couple of weeks, we're going to be doing naloxone training with them. And I think the idea is, and bringing that into our PT program is a lot of what you just said, Antoinette. And it's not that someone's going to necessarily overdose within the PT clinic. I mean, that could happen, but it's more about creating those attitudes, and it could happen. I had an experience where someone in my proximity reached out to me and asked for that immediately, urgently, and something like that. It could be a friend, it could be a neighbor, it could be anybody. That's that perspective of treating it like CPR. And when you look at the numbers, out of hospital cardiac arrest is like at 360,000, a year. We're at 100,000 opioid related overdose deaths. There's probably close to 1 million overdoses. It's hard to quantify that, right? But it happens a lot. So all right, so let's talk. I know there's a couple comments in the chat, but I want to round out this discussion talking in this treatment space about, what can we do? Let's say this comes up in a setting where we're working with a patient, and like Antoinette, I think you mentioned, really, if you're going to screen for something, you need to know what to do. So like, what are some of the things that PTs can start looking to getting more training, or looking for resources to figure out what they can do?
So I think from my perspective, I'm not in clinical practice right now. I primarily am research and teaching. And so I think, if I'm back in the clinical space and a patient brings this up to me, what would I do based on what I've learned in my research and interacting directly with people with opioid use disorders? And I think the first thing is to let people know they're seen. And I think this is true for so many things that we do. Part of what we can do is let people feel that they're seen. And I think on the front end of that, or if we think more, prior to that encounter, how can we be prepared going into it? So I think we all, if I was going back into the clinic, I would figure out who the addiction specialists, counselors, who are the people around me in my network. I don't think we have to feel like we have to be experts in substance use disorders. Just like so many things that we do, we just have to know who those people are and who are those people in our environments, who are those people we can make linkages to, so that we have a warm handoff that can happen. And so that'd be the first thing I would do. And I think that's true for behavioral health and social welfare. So if a patient comes into me with concerns about opioid use, who is the first person I can call to address that? If someone's coming to me with psychological distress, who are people I can talk to about that? If someone's coming into me with food or housing insecurity, who are the people that we can link people to, because we are the people who might be the first conversation that they have about this because of those relationships. So we should hopefully, and I think more clinics and hospital systems are doing this, be able to provide a warm handoff to people and be even just an advocate referral source to get them to the right people. But first, they have to be willing to tell us in the first place that these are concerns that they have. And then I think the next step would be, do we need the training where we can do something more point of care related to, we haven't talked about it yet, but kind of the screening, brief intervention, referral to treatment. Some of these other more technical things that are out there where we can be maybe providing, more point of care related to substance use. But I think before we even get there, we just need to find the people who are already doing this work, because there are a lot of them out there, and we need to be able to figure out how to create those warm handoffs for people.
Yeah. Go ahead, Jake.
Oh, I might just say that it's easy if you work in a healthcare system, maybe, to do that, to create that opportunity. Knowing your resources, like Antoinette mentioned, is incredibly important. There are plenty of places where, gosh, there just aren't them. There aren't resources. So having good relationships with primary care, if you work in a rural environment, which is where patients are, one of the risk factors for opioid use disorder is living in a rural environment, and understanding who primary care is. There might not be any addiction related counselors or physicians in the area within 100 miles, and so it might be understanding having good relationships with primary care in that setting. And when we encounter these people, and I really like what Antoinette said about meeting those people where they're at that moment, and really speaking to them using non-judgmental language, not perpetuating any stigma, feelings of stigma that they might already have about themselves, and for us not being a part of the stigma problem, that stigma can be institutionalized and then just perpetuated by the providers, and then passing that stigma, making it worse for the patient, the things that they already feel. So being able to communicate with those patients in non-judgmental ways, like Antoinette mentioned, is really critical.
And I think you make a good point, because part of the research that we're doing is looking at not just metropolitan areas, but suburban and rural areas. And the resource and the infrastructure is very different depending on what community you might be in. And so I think also expanding our vantage point about who are people that we can engage with in terms of multidisciplinary care. And that might be harm reduction organizations or other community-based organizations or places that may not be considered medical, but they may be interacting, they may be the ones that are interacting most closely and have the resources that we don't, or the knowledge that we don't, or the trusting relationships that we don't. And sometimes those are the people that the referral needs to happen. And we need to learn how to engage with organizations like that. And some of those things can start by doing things like naloxone training, making relationships with our public health departments, and also making relationships with, places that we might not think of. In our area in Wisconsin, there are a lot of these mobile integrated health services or paramedicine, or places that are doing kind of these overdose responses that are more mobile, going to people's homes. And so there's a lot of different things out there. I mean, the opioid crisis is touching every community, and communities are having to get real creative about how they're going to address it within their own communities. And we have to just kind of challenge ourselves to understand what's going on in our communities so that we can be part of some of the things that are already happening. And there are a lot of things happening and a lot of funding that's gone out to try to start to create some infrastructure. But a lot of times the challenges is things are not connected. And so everybody's kind of working in isolation and finding ways to make those connections so that we're all, like I like to say, paddling in the same direction, I think sometimes is more of what needs to happen versus us trying to recreate the wheel and feel like we have to do something that hasn't yet been done.
Yeah, and I'm thinking those are some great points. And these are some things that occurs to me that we already know, like about like patient care, using principles of patient-centered care, like asking them if this is something that they would want to engage with, like before, like, dumping a bunch of information on them, but like understanding, like, where they're at in terms of their readiness. So yeah, and I think it's some more work than we're used to doing, it sounds like, too, like reaching out to some of these community organizations. But that's what it's going to take, likely, to get these people connected because of our healthcare system. So we have a couple questions in the chat. There's one, I think, Weston says about to Antoinette specifically. Can you speak to your experience in public health related to opioid coming from a physical therapy background? I think this is something you kind of mentioned in your intro, but like, speak to like a little bit more in depth to that.
Yeah, so, I came to public health later in my career, and it's something that, if I had known about it sooner, that might have been the direction I had gone in, because I really enjoy population health and, being out and doing some of this primary prevention that, we often talk about but aren't able to do. I mean, there's a lot of things in public and population health that I think we are starting to become more familiar with and wanting to engage more with, versus that kind of individual clinical care that, is really how we're trained. And so I can say that my physical therapy background and understanding how health systems work has been really helpful. You assume that everyone knows things like how a clinical workflow is. And oftentimes people will say, well, why don't you just, or why don't they just? And you say, oh, let me give you all the reasons why it's not that simple. And I think the other thing is having conversations with people about pain and about how there are a lot of things that can contribute to a person's pain, including kind of that biopsychosocial model. So I think, what I've learned is that PTs, the way that we are trained, we have a significant contribution to make in terms of our understanding of patients and their environments because of the amount of time that we spend with them, some of their fears around pain and medication and movement, and also how health systems work and how we can help, kind of bridge the what I call a divide between kind of some of the more traditional health services and what you might see more out in the community or within the behavioral health realm. And so I think offering that perspective, both from, my experience with patients, but also my experience as a clinician, was really well respected. And it is a different perspective than that of a physician. And I think that's something that people don't always appreciate. We're medical, but we're coming from different disciplines with different philosophies.
All right. Well, thank you. I want to pose a brief question to you all. I know we're up on the hour here, and I want to be sensitive of everyone's time. But if the PT wants to learn more about the opioid crisis, or and in this space that we've been talking, like, do you have like one resource or something that's a direction to point them?
Oh, that's a tough one.
I'll go first. You guys can think. I really like the books by Sam Quinones. He wrote the book Dreamland, and really, if you want to understand the complexities of fentanyl, a book he just had come out recently called The Least of Us, which really goes in. The first book, Dreamland, talks about Sacklers and the rise of black tar heroin, and how those two things parallel to create the start of the opioid crisis. And The Least of Us goes into kind of synthetic drug making illicitly, like fentanyl, and it also goes into methamphetamine. And I think he does an excellent job of like putting a human face to a lot of this, and a well-rounded perspective, not just the medical perspective that we're so used to being a part of, but the larger perspective. So
Eric, can you post that title?
Yeah, I'll put the Dreamland is the book, one of them, and then The Least of Us.
And that was, if I had to pick one book, Dreamland would be the one that I would recommend. It's written in a way that's both informative and so engaging, and as you said, that it allows you to really enter into the topic no matter what you know about it, and really understand a lot of the complexities of it. And he just weaves all of these stories together so beautifully, so it doesn't feel like it's required textbook reading.
Right. Yeah.
Can't wait to read it.
Do you guys have any other ones?
I don't have anything that is that provides that great overview. I would refer people to Todd Davenport's article in 2020 in PTJ that does a nice job of outlining kind of physical therapy's role in the crisis. I thought it was nicely done.
And I would say, in terms of maybe just one action item, I would say challenge yourself to go get training in Narcan. Even if you can't do it through your setting, usually there's free trainings out there. And I think if there's one thing, just to kind of dip your toe in the water, that might be a good place to start. And then you'll be trained, you'll learn a little bit about it, and you'll be able to potentially save someone's life in the process. So it's kind of a win-win-win.
Great. Well, I want to thank you both for again joining me for this hour on a Wednesday. This has really been a great conversation. I look forward to seeing where your research comes out, and the stuff that all the findings and interesting things that we talked about. Yeah, have a great rest of your Wednesday evening.
Thanks. I really enjoyed it. Great to see you both.
Yeah, same here. It's a great conversation.
Thank you very much. That was great.
Thank you. I'll just say, I know we got a few other people just hanging on here, but I thought that was nicely done, Eric.